when there's nuance, when there's a gray area, when the person that you go to get started on birth control says, well, it depends, that's actually a good sign, even though uncertainty is so uncomfortable. I find it helpful to talk about, okay, what happens if you get pregnant? Like, is getting an abortion an option for you? Isn't necessarily trying to make the perfect choice or the right choice. I actually think that that's an unfair goal to carry, but the best possible choice with the information that we have now.
I know with social media and everything that we see online, the pill is not having a good rep right now. Could you talk a little bit about the side effects or risk and what is real and maybe what is not real?
Why don't we provide more pain management for inserting IUDs?
So now we'll move on to the vaginal ring. Could you explain a little bit like how it works? Can people feel it?
What is the best option of birth control if you want to avoid systemic hormones and also avoid the pain of getting an IUD?
Welcome back to the Vulvolution. So we're so excited for today's episode. We're talking about contraceptive. So we know there's so many different contraceptive methods in Canada that are available to us, but we want to know what's really best for us.
Yes. So how do they work? What are the different options? And which one is really best for you? Today we are joined by Claire Frampton, a registered nurse who works for Options for Sexual Health. Claire is also a student at UBC working towards becoming a nurse practitioner. And we do want to disclose that today Claire is talking about her views and they do not reflect those of any of her affiliated organizations. So welcome to the Vulvolution, Claire.
Thanks for having me.
So excited for you to be here today. And this topic especially, we've had so many requests to do an episode on, so glad to finally be getting into it. So tell us a little bit more about you and what brought you into the sexual health and contraceptives field.
Thanks for asking. Well, I am a big sexual health nerd, and I would be talking about this stuff otherwise, even if I wasn't on a podcast. So thank you so much for the microphone. So I did a social sciences undergrad in Ottawa, which is where I'm from, and I did co-op placements, and I had like a scholarship, and so I had all this extra money at the end of my program, and I lived at home, so I saved money. And any reasonable person would have taken that and gone backpacking somewhere, but I decided to do the SHEC program at Options for Sexual Health and travel to Vancouver for the first time and, learn how to do sex ed. I had hoped that it would inform my master's. Like I was just going to go back and do a master's. And then I fell in love with Vancouver, and I fell in love with sexual health and Options for Sexual Health as an organization, and I moved here and I started working for Options, and then the leap into nursing was truly because I worked with some really badass nurses, and I thought, I want to be like them, I'm going to go to nursing school. So that's the process.
Beautiful. I love the transition.
Yeah.
Oh, yeah. It's great. It's, everyone finds their way in a different way. And
absolutely.
Yeah. Okay. So for this episode, one of our biggest questions that we got from people and that we have ourselves is, what is the best method of contraception for us? How do you approach answering this commonly asked question?
Thank you so much for asking. I cannot tell you how much I think about this. It would be so easy if I could just tell you the Nuva ring is for you and you, the pill. But it is not that simple. And I actually think that that's a good sign. When there's nuance, when there's a gray area, when the person that you go to get started on birth control says, well, it depends, that's actually a good sign, even though uncertainty is so uncomfortable, right? And it's, I would say, an equally bad sign if people have that unearned confidence, that certainty that they're pulling out of nowhere. If they're like, take this supplement and it'll cure your symptoms overnight, 100% guarantee. Or they say to you, well, I just start everybody on the pill. That's everybody's first birth control because I'm their nurse practitioner and I said so. What we actually want to do is compare the options and go through a process that isn't necessarily trying to make the perfect choice or the right choice. I actually think that that's an unfair goal to carry, but the best possible choice with the information that we have now. That's what I'm always aiming for. So I have a systematic process. First, I want to know, do we have any like good medical reasons why you can't use some forms of birth control? There are certain contraindications is what we call them. So really good reasons that somebody shouldn't be on a pill with estrogen in it, or somebody like shouldn't have an IUD. Then we don't have to worry talking about those ones, right? Then I want to know, what do you want out of your birth control? What do you not want out of your birth control? That'll help me whittle it down more. I also want to know, what information are you bringing to me that I don't have? Like I know in theory what birth control does what, and you know what might be a good fit, but people know themselves best, and I want to know like what is their risk tolerance around certain side effects? What is something that they absolutely wouldn't consider? Or what misinformation maybe they have about what's involved in using a certain method of birth control? And can we shift some things? Can I tell them about options to make something more accessible? So the approach is that it's a process. It's not like instant gratification. And then if I may add, this is where I get on my soapbox a little bit. So I really think that a practitioner's job is what I've been calling risk stewardship. So if you're coming to me and you're saying, I want to use this form of birth control, I'm going to give you all the information that you need to know about that birth control. We're going to talk about the alternatives. We're going to compare the risks and benefits. And then the decision is yours. And I don't really have a stake in that. Like even if it's not, it wouldn't be my top choice, or it wouldn't be my top choice for you even. Whatever choice you make, I stand by you for the consequences of that choice. So if you are choosing to use, let's say, like a less effective form of birth control, and then it doesn't work, you happen to get pregnant, there's no, I told you so, there's no gotcha. If you come to me and I say, well, the most effective form of birth control in Canada is the implant, and then you try the implant and you hate it, I'm not going to be like, well, it's really effective.
Yes.
So you should like it. Your experience should be different. My job is to walk with you through the consequences of whatever choice you make. And as long as we're deciding we're making the best choice that we can with the information that we have now, if things go sideways or they're not ideal, then you come back to me with more information. We have the opportunity to make another best choice. So there's no like BuzzFeed quiz. Do you know what I mean?
Yes.
Like it's and also there are very few wrong answers. Like most people are eligible for most options.
Yeah, it's very personal, the choice that you're
but I really like that whole stewardship.
I'd made this up. I call it risk stewardship. I don't know. Maybe that doesn't speak to it, but I just think about it as like, I recognize the vulnerability of every client who comes in to try any medical intervention. Birth control especially, because it's so politicized and it's so personal, and there's a lot of misinformation about it, and it like has to do with a stigmatized area of life, like sexual and reproductive health. And so I recognize that vulnerability, and that every medical intervention is a risk. You're taking a risk for some benefit. And I would never fault anyone for if it doesn't go well.
Yeah. No, I love that.
Yeah.
Okay, outside of just preventing pregnancy, what are some general things people consider when choosing a contraceptive?
Yeah. It's a good question. Birth control does a lot of things. Also, we call it contraception to make it clear, but we're using it as treatment for lots of different conditions. So even people who aren't sexually active or sexually active in a way that could get them pregnant are on contraception because it can do so many things. So the big one is menstrual changes. So if somebody has really heavy periods, if they have endometriosis, or if they have polycystic ovarian syndrome, if they are anemic, if they lose a lot of iron with their periods and they're just having such a hard time replacing it, sometimes if we use a birth control that suppresses menstruation, it can really help them get ahead of that iron loss. So there's lots of different things. It can be supportive for mental health in different ways. So if somebody has PMDD, which is a more intense version of PMS with like very specific diagnostic criteria, sometimes we do also put them on a form of birth control to help with that. So there's a lot of things to consider. So often people do come to me and they're like, I just don't want to get pregnant. And then I'm like, oh, okay. Anything else? Or they come to me and they're like, I don't really care about that, or, it'd be nice to have contraception, but what I'm really concerned about is acne, for example. Some birth control can reduce acne.
So it's really not just not to get pregnant.
Yeah, there's so many different things to talk about.
And even like the perimenopause and menopause period, when pregnancy is like in perimenopause, very unlikely, and then in menopause, not possible, we're using IUDs. Did you know this?
Yes, actually.
Oh my gosh. We love a hormonal IUD for menopause. So it can even be part of menopause treatment when pregnancy is not even
on the table.
on the table. Yeah.
Okay, so many different uses. I feel like we're going to talk so much about lots of different things.
Yes.
So true.
Shall we get into it?
Yes. Okay. So for this episode, we wanted to organize our discussion into different contraceptive methods and effectiveness. So we want to start by talking about the least effective methods, which is not necessarily the BAP method, just like the least effective. So these are methods such as condoms, the diaphragm, or the withdrawal method, which is what we know as the pull-out method. And then there's also the fertility awareness method that we'll talk about. So according to Options for Sexual Health, on average, there's about 12 to 24 out of 100 people using these methods that get pregnant. So per year of use. Very important. Yeah. Not forever.
That would be really good.
In like a lifetime of somebody using this method, that would be pretty good.
Yeah.
But yeah.
Per year.
Okay. Why are these methods less effective?
The short answer is user error. And I don't mean to sound like blamey about that. It's just that these methods require a certain amount of skill and then also luck. So you need a certain amount of skill with the withdrawal method. Like you have to have quite a lot of body awareness, and you also need to be able to trust your partner to be good at this if you're not the person making the sperm. You need to be able to buy and store condoms effectively. Like you can't put a condom in your pocket and leave it there for 2 weeks and then trust that it's not going to break. But also sometimes they just break.
Sorry, can I stop you
Yeah.
there? I didn't know that. So
Yeah.
Yeah.
Like, because you have to store it at like a
it's
certain
the warmth,
temperature?
Yes, it's the warmth of the body.
Oh, interesting.
So like heat and oil breaks down condoms.
So if you have
Okay.
one in your pocket for 2 weeks, it's probably going to break.
Yeah, or if you like have an oil-based makeup, lipstick, or lip balm on, and then that gets onto the condom, it will start eroding it. Isn't that wild?
Yeah.
Or if you're like, oh, I forgot to check the expiry on these condoms. Like, it's just another thing to think about. The other thing is that it's about being consistent. So like humans have a hard time being really consistent. We'll talk about this more with the pill, taking the pill. But you're really fighting against time and so many variables. So it makes sense that they don't work as well.
Yeah. Okay. And that number that we quoted, 12 to 24, was different for the different methods. Which of those is the more effective?
That's a great question. I think what I want to say about them is it's quite variable based on how good you are at it and how consistent you are at it. Each one. And also, one thing I'll say about the fertility awareness method is if you're somebody who has a really stable, consistent life and a predictable menstrual cycle, which is not everybody, it's much easier to do. But
Right.
if you're like, what if you're somebody who travels to a different time zone every other month? Like it's gonna be so much harder to do fertility awareness. So yeah, these are really, really context specific ones. Whereas ones that we'll talk about later are sort of more buffered from those variables and buffered from user error. And that's part of why they're more effective. And then also partially just the technology involved.
Okay. And when we talk about fertility awareness, it's like the apps that we're using and to know when you're ovulating.
Yeah, it didn't used to be apps. It literally people could do it on a piece of paper, and they did. And if you're really, really consistent, it can be quite effective, but it's never going to be as effective as something like an IUD or an implant. The apps, I will say, can be very helpful because we all have a phone in our pocket and you don't have to like lose the piece of paper that you're using to track your ovulation. And it can be more powerful if you're logging your morning temperature before you get out of bed, like your oral temperature, and also you're like checking your cervical mucus, and then you can log that. But the apps definitely make promises around effectiveness that I feel dubious about. Whenever we're doing research, we have to be very careful about who's funding that research, what their investment is in the outcome of that research, how rigorous they are. So whenever I call it sniffing the data, like whenever I sniff the data that informs these apps, like the claims that they're making around fertility awareness, something smells funky.
Right, because they're trying to get people to use their own app.
Yes, for sure.
So
and
there's
so
some
they'll say
incentive
like,
there.
oh, it's as effective as a birth control pill. And it's just, we do not have the evidence to suggest that.
Okay.
Like if you were really bad at taking your birth control pill and really good at doing fertility awareness, maybe that's true. But when we're talking about like a population level of 100 people are using the app, 100 people are using the birth control pill, we're just not going to see the same effectiveness with fertility awareness.
Okay, and generally speaking, who might be a good fit for these sort of lower effectiveness contraceptive methods?
That's another thing I love talking about. So when I was training in sexual health, and still the training in sexual health talks about reproductive desire as a binary. People either are like really wanting to get pregnant, actively trying, or they do not want to get pregnant. They will go to the ends of the earth not to get pregnant. And that's just not how the world is and how people are. It's complex. So there is something called ambivalence in reproductive desire. Like people are sometimes ambivalent about wanting to get pregnant. And that's valid and fine. If we're saying that, you know, your body, your choice, that's part of it. You're allowed to be ambivalent about it. So I definitely have clients who come to me and they're like, well, I don't really want to like put my all into trying to get pregnant right now, but if it happens, like, great. And so for these lower effectiveness methods, especially ones that don't carry hormonal side effects, which I guess is all of the ones that we're talking about right now, like, great, sure. Like if you're happy, I'm happy. Again, it's about informed consent. If you know the risks and benefits, and if you know that one of the risks is this many people in 100 per year will get pregnant, and that there are more effective methods available, but actually, if you did get pregnant, it'd be fine. It wouldn't be the end of the world for you. Great, I'm happy.
Yeah, I think that's such an important thing to talk about because I think you're right that it's not a binary. Some people are in a position where they're like, I'm not actively trying to have a child necessarily, but if I did, I wouldn't be mad about it, you know? So I think that's a really important clarification.
And I'll say one more thing. So there are folks who just cannot tolerate hormonal birth control of any kind. Like they're not able to tolerate the risk of having hormonal side effects, or they've tried hormonal methods and have had a bad time. If all that's left for them, like once they've exhausted all their other options, is the withdrawal method or the fertility awareness method, like I think those are useful for those folks.
It's better than 100% chance of pregnancy.
Yeah. And I think it's tempting as a healthcare provider for somebody to come in and say, oh, I'm using the fertility awareness method. And we are taught to make sure that people are aware. It's important that people are aware that they have really effective options available. But I would really caution healthcare providers against rolling their eyes and saying, oh, the withdrawal method, like, well, call me when you get pregnant. I think it's very easy to fall into that pattern. Whereas I actually think that people are making the best choice that they can with the information and the resources that they have. If somebody comes to me and they say, I want to use the fertility awareness method, you know, I have my reasons for not wanting to consider any other options, I will support them as their healthcare provider. Of course I will. Of course I will.
Yeah. I like your point of view because I have a lot of friends that went to the doctors and they told their doctor that they're not on anything and they don't want to be on anything.
Yeah.
And they got the like eye rolling and just like, all right, well, you know the risk, and just like as if it was their decision that, you know, you're going to get pregnant, but don't call me for anything. Like, it's sad.
And what I would say is if somebody did come to me and they were using a less effective form of birth control, whether they knew it was less effective or not, and they did happen to get pregnant, the way that I would interact with them is the exact same as if they came to me and they're, you know, one of the very few people who got pregnant with like an IUD or they were pregnant for any other reason. We have the exact same conversation with everybody, or we should. And that is, okay, we confirm that you're pregnant. How are you feeling about this pregnancy? What do you want to do next? Do you know what your options are? We'll talk about the options, which is continue the pregnancy and make a plan for parenting. Either you're parenting, someone else is parenting, or you can end the pregnancy with a safe, routine medical procedure that is covered by MSP called an abortion. And then we help arrange that. We do not need to go into, well, why weren't you on birth control? Or it's just not necessary. It's not helpful for the therapeutic relationship. It's not helpful for the client.
Yeah. Wholeheartedly agree. Okay, before we move on to some more effective methods, I do want to also give you the opportunity to explain why it's also important to use condoms in addition to other contraceptive methods.
So the other thing, condoms give us something that no other form of birth control gives us, which is STI protection. Incredible. I also find that some people, even when they're on the birth control pill, they just feel better when their partner is using a condom. And I think part of it is the STI protection for sure. But there's also just something like psychologically comforting to a lot of people about condoms, which I just want to say is valid.
Yeah.
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 Condoms also get such a bad rap. People associate condoms with actually less sexual pleasure, but some folks have the opposite experience. And a lot of it is like, whatever you think the condom will do for you, it probably will in terms of like reducing pleasure or increasing pleasure. But there's so much opportunity there for, like, if you're less worried about STIs, you're less worried about pregnancy, you're having more fun.
Yeah.
Because your brain isn't elsewhere. You put a drop of lube inside that condom, and then now things are shifting around in a different way. That can be fun. Putting on the condom can be part of sexual play. So I think that latex barriers in general get a bad rap around not being like fun or pleasurable, but I think that just means we're not being creative enough.
Love.
Yeah.
Anyway, yay condoms.
Yeah.
Forever.
Use condoms even
But
if you're using another contraceptive.
Don't leave them in your pockets for too long.
Yes.
Yeah. I'm glad to get the word out there. They don't belong in your pocket.
Perfect. Unless it's like you're on your way somewhere and you need somewhere to store it for like
short
a short
term.
time.
Yeah, for
You
sure.
can bring it.
Yeah.
Okay. Moving on to some more effective contraceptive methods. So next we're going to talk about the pill, the ring, the patch, and the injection. So on average, about 6 to 9 out of every 100 people using these will get pregnant per year, which is better than the ones we mentioned, but not perfect, of course. So let's start by talking about the pill, which I think is a big topic, especially online with a lot of misconceptions. So I'm really excited to talk about this. Can you start by just telling us what is the pill? How does it work?
Yeah. So the birth control pill, there's two kinds. There's one with estrogen and progestin in it. So 2 hormones, or the combined hormonal contraceptive pill. And then there's the progestin only pill. So that only has 1 hormone in it. And they do different things, but also kind of the same thing. So the combined hormonal contraceptive pill, it's stopping ovulation from happening. The progestin-only pill sometimes also does that, but not reliably. The thing that progestin does, whether it's in a combined pill or the progestin-only pill, which is that it thickens the cervical mucus, and then also over time, it'll thin the endometrial lining, making it less likely that a fertilized egg could implant. So it's kind of doing a few things.
Okay.
There are different considerations. So estrogen tends to be, like if somebody is medically ineligible for a kind of birth control, it tends to be that they can't have the estrogen. So things like migraines with aura, if they've ever had a venous thromboembolism, so like a dangerous blood clot, if they are over 35 and they also smoke cigarettes, if like there are all these medical contraindications for estrogen-based birth control. It used to be that progestin-only pills were sort of a consolation prize if you couldn't have your estrogen-based birth control. And the reason why is with the progestin-only pills, you would have to remember to take it within the same 3-hour window every day. Whereas with the combined pills, you get a 24-hour wiggle room. So we don't consider that you've missed a pill until you've missed it by 24 hours or more. But now there's a new progestin-only pill in town.
Okay.
And it's a new form of progestin called drospirenone. The brand name, I think, is Slind. They're not paying me. But the difference there is that people can have that same wiggle room of the 24-hour period with that newer progestin-only pill.
And sorry, what happens if you were outside of that 3-hour window? Is like
That's
side
a missed
effects?
pill.
And does it like
Reduce effectiveness.
Okay.
Yeah. Yeah.
You mentioned a lot about like who would be good candidate for the progestin only pill, like if you have migraine, but then I was wondering who would be a good candidate for the progesterone and just estrogen pill.
Yeah, so because we're reliably stopping ovulation, that tends to treat a number of conditions that are related to ovulation. So some people, like if they have PCOS, if we stop ovulation, they hopefully will have fewer cysts. Estrogen also has, and some progestins as well, have what's called an anti-androgenergic effect. So it opposes testosterone. And so if you're having like unwanted facial hair or body hair, or if you're having acne or those sort of like testosterone based concerns, it can be really helpful. Also, if you want really regular periods, like if you've always had a really irregular period, the pill sort of sets a schedule for your body to have regular bleeds, which some people really want. It can also be an option, maybe not our most powerful option, but certainly an option to have less bleeding, like lighter periods, lighter predictable periods.
And what about people who have serious cramping? Is it a good option?
Yes, it can definitely help. So
Okay.
because it's going to thin that endometrial lining, there's just going to be less to cramp out, less shedding of the endometrial lining. So it can be, a powerful option for those folks. It's, one of our first lines for PCOS, endometriosis. It can really help. It can also help with PMS and PMDD. So because it's sort of like shutting down ovulation, thereby reducing the roller coaster of your menstrual cycle, is how I tend to describe it.
Right. Okay. And there's lots of different variations of how much estrogen or progesterone there are in a combined pill. What is the difference, and why might people want one versus another?
Yeah. I encourage people not to worry too much about that. Like, a lot of it is marketing. Just know they all are effective for preventing pregnancy. Some of them have specifically been studied for certain indications, like acne treatment. I have on the corkboard of my clinic a chart that shows me, like, if somebody is having this side effect on their birth control, you might consider this pill instead. If someone's starting pills for the first time, it's kind of dealer's choice. Like, I'm not as worried unless they really want something that's been studied for acne, or they really want like a newer generation for whatever reason. People come in and they say, like, I know it's silly, but my best friend is on this pill and she's having a good time and I want to use that too. As long as they don't have medical contraindications to the pill, like, it doesn't actually give us evidence that it'll work for that person. But I think that the way that people feel about their birth control matters. And if they're excited about that, cool. If they understand that, like, the effectiveness, the risks, the benefits, and they're just stoked to be on a specific pill, like, that's actually a good enough reason for me to choose one over the other.
Okay. So you mentioned a little bit, like, there are some side effects. I know with social media and everything that we see online, the pill is not having a good rep right now. Could you talk a little bit about the side effects or risk and what is real and maybe what is not real that we've been seeing online?
Yeah, for sure. I mean, I think in general, so when we study pills, we ask people who take them, what side effects have you had? And then we list them all and how often they show up in the study. But if somebody came to me and they're like, ever since I started the pill, I'm having this side effect, or I feel this way, I tend not to say, well, it's not in the research, or, what are the chances of that? Only 5% of people had that side effect. I think it's all in your head. I'm never going to say that. I'm going to say, you're not happy? We can try something else, or we can talk about the risks and benefits of trying something else. But, like, the common side effects that come up are things that we think of as related to PMS. So, like, headache, abdominal pain, maybe they'll have breast tenderness, maybe they'll have mood swings. But there's also, technically, like, if you take the pill for contraception and you have really light, regular periods, that's a side effect, because that's not the main effect of the medication. That's all side effect means, is it's like an extra thing. So there's a big difference between desirable side effects and undesirable side effects. And that's so subjective, right?
Right.
So some people come to me and they're like, oh, I don't even get my period on the pill. And they're like, that's great. And some people are like, I'm not getting my period on the pill. I don't like that. So it can be very subjective.
Okay. So obviously taking the pill every day requires a lot of being able to do the same thing every day at the same time.
It's so hard.
Yeah. What happens if someone misses a pill?
Okay. So if you miss a pill, it depends on what week of the pill pack that you're in, how much it reduces the effectiveness of your medication.
I did not know that. That's interesting.
Isn't that wild? So what I recommend doing is, if it's between Monday to Friday, 9 a.m. to 9 p.m., call Sex Sense, because they will do there's a flow chart that they will help you with. If you're, like, really savvy on the internet, you can probably find the flow sheet yourself. Or also pharmacists tend to be able to help with this question. So it really depends, like, when it was and, like, what's the context. Was there unprotected sex in the last 5 days? Because that's how long sperm can live. The problem with missing a pill is your pills are suppressing ovulation, typically. And if you miss a pill, your body has a chance to ovulate. And then if there's still sperm in the reproductive tract, or sperm shows up in the reproductive tract in the time when the egg is available, you could get pregnant. So if you miss a pill and you're like, well, I haven't had unprotected sex, that, you know, it's not a huge deal. Just remember to take your pill and then keep going. But there are some exceptions around when the pill is going to be effective again.
Oh.
Yeah.
Like after you missed it.
Yeah.
Okay.
So the most important pill of a pill pack is the first one.
Okay.
If you've taken that 7-day break at the end of your last pack. So taking one pill a day for 21 days, for 3 weeks, sort of like buys you a week of no pills or sugar pills where you're not going to ovulate. It gets you 7 days. It does not get you 8 days. If you miss that first pill of a new pack, your pregnancy protection lapses. So not only could you ovulate, you are not protected again until you've taken a full week of pills.
Whoa, I did not know that.
Isn't that wild?
That is so interesting.
Yeah.
Wow.
And people should know that.
People should
Oh
know
my
that.
God, yes.
Yeah.
I feel like, yeah, I thought if I miss a pill, I just take 2 the next day and just don't think about it that much.
I mean,
but
sometimes that's fine. Like, it's very context specific. But if it's the first pill of the next pack, I don't consider you protected from pregnancy by that pill pack unless you've had one pill every day for 7 days.
Wow. Okay.
Now, here's a cheat for it. So you have your 21 pills, 3 weeks of pills, and then you have your 7 days. It gets you 7 days. If you are somebody who might forget that first pill of the next pack, you can shorten your hormone-free interval, the sugar pill week, to like 4 or 5 days. And then if you forget, you're actually only at 6 days. So you have a little bit of wiggle room. Nothing has lapsed. Your pregnancy protection hasn't lapsed. You get 7 days. You don't get 8.
wow.
Whoa. And
Yeah.
do you have any recommendations to help people remember to
really
take their
do.
pill on time?
I really do. Okay. There's a free app. They're not paying me. There's a free app called MediSafe. And it is, I speak from professional and personal experience. It's an app that is so helpful for remembering daily pills. It like makes your phone yell at you until you take your pill, until you've told your phone you took your pill. And you can snooze it, and you can like set different times, and you can also program it so it texts a med friend, like a partner or a sister,
Oh my God,
or whoever.
it texts someone else.
It'll text someone and be like, this person didn't take their meds, go bother them. I love it. I'm obsessed.
That's hilarious.
That's fun. So you
I
can
love
put your
it.
partner, and then your partner can
Yes.
tell you to take your pill.
Yeah, because
Way
like,
to
why should it all be
offset-
on
Yeah.
me to remember?
Yeah, offset some of that labor.
Wow.
Yeah, MedSafe, y'all. Download
Okay.
that.
Fantastic.
I also just want to say, if you're somebody who has a hard time remembering to take a daily pill, even if it's a really important pill, like contraception might be to you, welcome to the rest of the, like, everybody's in that same boat. It is just truly a hard thing to do. And it's not like a moral failing. It's not like a cognitive failing. It's just difficult. So some people like really beat themselves up about this, and I'm like, no, this is standard. Like, we know that this is hard, and if you're sick of it, we can talk about a less labor intensive birth control method.
Yeah.
Okay. Yeah. And you talked about the estrogen and progestin pill, that you have more time to take it, like a 24-hour
Yes.
period.
Yeah, so a missed pill, when you're taking a combined contraceptive pill, is you've missed it by more than 24 hours. You were supposed to take it at 9 p.m. on Monday. You didn't take it until 10 p.m. Tuesday.
That's so interesting because I feel like when I originally started on oral contraceptives, my physician told me to, if I miss one, wait and take it with the one after
Yeah,
that.
me
Is that
too.
not what is recommended anymore?
Well, it depends where you are in the, like, how long you've missed it for and what week you're in. But yeah, so you might be taking 2 at the same time. So if like you didn't take it on Monday night and you remember on Tuesday, you probably are going to take 2.
But if you remember before that, just
Take
take
it. Yeah, take it when you remember.
Okay, good
Yeah.
to know.
Okay.
Because again, you need to accumulate those 21 pills, 21 days to get your 7-day break. And then that's also true of the spironone progestin only pill. You get that 24 hours.
Right.
Now, I want to be really clear. If you want to maximize the effectiveness of your pill, take it around the same time every day.
Right.
Like, don't push it with that 24-hour wiggle room. But when we're talking about missed pill guidelines, like what to do and how to minimize risk when you've missed a pill, that's our definition, is you've missed it by 24 hours or more.
Okay.
Okay. Okay. So when you realize you missed it, you just
Take
take it. Okay.
Clear as day. Okay. We have a couple questions that were directly submitted from our audience about the pill for you now.
Yes.
So the first one is, how long does it take for your body to regulate? And regulate, I think, could mean a lot of different things. But in the context of this, let's say like your periods to become normal again after coming off of the pill.
Yeah. Yeah. So there's a few different answers to this. The first one is, if you're wondering when you could get pregnant after stopping the pill, it could be in like the 24 hours after a missed pill. Like if you miss the first pill of a pack.
Right
away. You can ovulate and get pregnant right away. When we're talking about like how long will it take for my periods to become regular, if they ever have been or ever will be regular, so that I can track ovulation to try to get pregnant, typically we're talking about 2 or 3 cycles. If you're saying, when will my body go back to baseline, maybe a little bit longer than that, but usually we're talking about 2 or 3 cycles.
Okay.
I don't know if you've seen online, there's a lot of things about the like getting off birth control syndrome or something.
I don't know what that means because it's not a syndrome based in evidence.
Okay.
Right? But like the feeling of coming off birth control, I'm not saying it doesn't affect you. Of course you're going to have. And I tell people this, like, part of informed consent is not just starting birth control, but discontinuing it. So if people are like, I really want my hormonal IUD out, I say, great, please expect your menstrual period to get heavier.
Okay. Because I think what we've been seeing online is like the fear of like, oh, you've been on birth control pill for maybe 10 or 15 years.
Yeah.
And then when you get off, you don't know what it's going to be like.
What
and,
are
like, you
people
don't know
saying
yourself.
happens?
Acne, like your period never comes back.
Yeah,
I think there's
lots
a lot of
food
misinformation
intolerance,
Interesting.
cramps.
I mean, acne makes sense because birth control, like estrogen-based birth control, does treat acne. So if we're removing a treatment, that makes sense. The rest of it, I'm not sure is based in evidence, but it's not that I don't believe people's experience. I have heard the thing of like, you get off birth control and then all of a sudden you're like attracted to different people.
Yes.
That I don't think has any evidence backing it up.
Yeah.
Okay, another question from our audience is coming back to the birth control pill. So this person says, if I miss one birth control pill and I take 2 the next day, I start spotting, and then I spot until I get my actual, like, the bleeding of the period after, and they're wondering if it's normal.
It's a known sort of side effect, potential side effect of missing a pill or like not taking it consistently. That said, even if someone does take it consistently and they have spotting, it could still be from the pill. But yeah, that makes sense to me. It's not like dangerous or like a red flag that we would have to pursue. Certainly if someone like really consistently had bothersome spotting or we didn't have a good explanation for why they're bleeding, yes, I want them to be seen and that to be investigated. But yeah, that makes sense to me.
And could that person come in for counseling or whatever and potentially be put on a different pill or something?
Yeah. I mean, if it's never happened before and it's just like I missed a pill, I took 2 at the same time and then I have spotting, like if it's a one-off, I'm not that fussed. But if it's like a consistent thing that's happening, or if the issue is actually that they're missing so many pills,
right,
then maybe we talk about, other options. Yeah, I mean, I'm just always open to troubleshoot these things.
Right. Which is the right way to be.
Come on down to options.
Okay. Yes. Another listener wrote in that she tried the pill and felt extremely emotional and even suicidal. She tried 6 different pills. Is there any known association between birth control pills and depression?
So mood changes are a known side effect of hormonal birth control. It doesn't happen for everybody. It happens for some people for sure. And it can go in either direction. So some people do feel much worse in their mental health on the birth control pill. And the opposite is also true. For some people, they're like, now I don't get depressed, or my anxiety is much better, or whatever it is. So if somebody's coming to me and they're like, I'm having this side effect from birth control pills, I just believe them. And also, I just want to say to that person, trying 6 different pills, like, you really gave it a try, like a really good try.
Yeah.
And I think that that's trying any medical intervention that doesn't have a 100% guarantee of success, which is all of them, is a vulnerable and I think also loving thing to do for yourself. Like, I actually think that's very brave. And so good for you. If it were my client, I don't know that we would have gotten to 6. I think we would have given up earlier than that, but that's okay. And yeah, I believe them that that's their side effect. And for somebody who had a side effect that got to the point of suicidal ideation, I would actually call that like an adverse effect from a medication. And I would really hesitate to put them back on that medicine. So I think it's actually important to tell your provider, this is what I experienced on this medication, so that we can take that information. Like if you had a terrible allergic reaction to another medication, like we would want to know, I would want you to tell me. So that's true about birth control as well.
Yeah.
Okay, so we could talk about the pill for hours.
Yeah. Oh, I know. Oh
and
my
we
God.
there's just so many questions.
Okay, wait, I have one more.
Yeah,
before we
please.
finish.
Please.
It's just, how long is it recommended to take the pill? Like, is there a time limit? Like after 10 years, you got to get off of it.
No.
Okay.
So you can be on the pill for as long as it's working for you and as long as you're happy with it. The thing that changes is people's medical picture changes with age. And so we do want to check in with people whenever we're renewing that birth control prescription to make sure, has anything changed? Are there any medical contraindications that have come up that would be a good enough reason for you to stop taking the pill? But it's safe. No evidence that it affects future fertility. So often when we see birth control pills in the news or there's backlash about them, it has to do with blood clot risk. And I just want to be very clear, in general, these pills are very safe. People who are at elevated risk of dangerous blood clots, we don't tend to put them on the birth control pill with estrogen in it. The underlying risk of blood clot, like a dangerous blood clot, is quite low. And it is true that the combined hormonal contraceptive pill increases that risk of dangerous blood clots 4 or 5-fold, which sounds scary, right? But if I said to you, I'm going to give you some money and I'm going to give you 4 or 5 times more money than you get, what's your first question?
How much money?
Yeah.
How much money are we talking about, right? Because if I'm giving you a quarter, then you're getting $1.
Yeah, that sucks.
And like, that's not enough to buy a bag of chips. No. So what are we talking about? We're talking about actually very low levels of risk. And then also we need to compare being on birth control to the alternative. So certainly like not being on birth control is slightly lower risk for dangerous blood clots. But getting pregnant or the 3 months after having a baby, the blood clot risk is astronomically higher than being on birth control. So we're actually probably, by putting people on birth control pills, reducing the overall level of blood clots because we're preventing pregnancy.
That's super interesting.
Yeah.
I think that's a great comparison to
I
make.
didn't know that. Yeah.
Thank you for talking about that.
Mm-hmm.
You're very welcome.
So now we'll move on to the vaginal ring. So it's similar effectiveness as the birth control pill, but I feel like we don't talk about it as much.
No, I didn't know about this until like last year.
Yeah, I know a few people that are on it, but even them, I don't think they know fully what it is. So could you explain a little bit like how it works and what it is?
So it's another combined hormonal contraceptive. So it has that estrogen piece. The ring, it's like a plastic, like soft, bendy material. And you kind of like fold it up and you put it inside the vagina. And because it's sitting inside a mucous membrane, vaginas are very absorptive. Like they'll absorb whatever is there. So the hormone kind of leaches out into the mucous membrane and then through the bloodstream. Because of that, we are bypassing your GI tract. So like when you swallow a pill, your body has to metabolize that pill through your GI tract. And so actually the amount of hormone that we give to you is less than what ends up in the bloodstream because your body's kind of getting rid of some of it. So one nice thing about the ring and the patch as well is we're bypassing the GI tract, and so we can get away with less hormone. The other thing is if we're delivering estrogen right to the vaginal canal, we can actually treat a little bit of what we call it vaginal atrophy. So if somebody has low estrogen, maybe they're in perimenopause, but they still want birth control, the estrogen from the vaginal ring can actually help treat some of that estrogen deficiency. People find that they have less dryness, less like fragile tissue. So that's a consideration. The other nice thing is you don't have to remember to do something every day. You put it in and you can leave it for 3 weeks and then you take it out again for that up to 7-day period. You get 7 days, you don't get 8. Yeah, people who love it. And then some people are like, I don't want to have to put something in there. But I would say it's probably more comfortable than a tampon because it's made of like a material that kind of softens with the heat and moisture of your body.
Okay. I was going to ask, can people feel it?
Sometimes. I would say if you can feel it and it's uncomfortable, it's similar to a tampon, like not far enough in past the pubic bone. You certainly don't have to take it out for sex. You can if you want to, as long as it's not out for more than 3 hours. You're okay.
How is it working compared to the pill? Like, is it suppressing ovulation? Is it
Yes.
making the cervix?
Yeah, because it's the combined hormonal contraceptive, it's suppressing ovulation, and it's also going to do the work of making the cervical mucus thicker and then also thinning the endometrial lining.
Okay. And is that true for all like combined contraceptives?
Yeah.
They're all doing the same thing, just you're getting the hormones through
Yes,
a
we're
different
delivering
mechanism.
the hormones differently.
Okay, good to know.
Okay.
Does it ever fall out?
Yeah, sure, maybe, probably. Like, I'm sure it's happened. But if it's falling out, it's probably not in far enough, or maybe you're having an issue around like prolapse that you should chat to somebody about. But I don't think that people tend to find that a problem.
Okay.
And if it falls out, you just put it back in.
Okay.
That's a good point.
And then you mentioned you can take it out for not more than 3 hours.
Yeah.
Where do you put it? What's
Oh, I don't know, like a dish or...
okay?
I don't know, it doesn't
But
really
you don't-
matter.
Okay, it doesn't like dry up and then
No,
okay.
and if it does, it just get
Okay,
moistened
okay.
when it goes back down.
Sweet.
Oh.
Sounds pretty good. What are the benefits or like common side effects?
So it's going to be like a similar profile to the combined hormonal contraceptive pill, but like in theory less likely to have those side effects because we're not giving you the hormone orally,
Okay.
but usually similar stuff. But that also means the acne benefit will be dialed down a little too.
Right. So like side effects, which can be good and bad,
Yes.
will all be reduced.
Yes.
Potentially.
Yeah.
Okay. Similarly, the patch, as we've just said, works the same. Where does it go? It's like, what is the patch?
Yeah. So the patch is not that popular, honestly. I think it's because it has a level of medical adhesive that sometimes gives people a rash. And also it's easy to sweat it off. But like if people like it, they like it. I actually forgot to look this up if it's covered by MSP, but when MSP initially started covering birth control pills, it wasn't covered.
Okay.
Or like birth control in general, it wasn't covered. And neither was the ring. But then there was so much backlash about the ring because people love their Nuva ring. When they love it, they love it. And they were like, why can't I have this covered? So anyway, now the ring is covered.
Okay. And
Yeah.
no one was like, oh, I love the patch so much.
I didn't
Not
hear
the same uproar.
I didn't hear anyone upset about the patch. But yeah, it's like a sticker. You put it on your body. You replace it. I think it's every week. I've truly never started someone on the patch or seen someone on the patch. That's how
Rare
like,
it
in
is.
my practice. It's
okay,
how
okay.
rare it is.
But you can put it anywhere on your body?
No, absolutely not. So places you're allowed to put the patch: your stomach, your buttocks area, your upper arm. Most places on your upper body. You're just not allowed to put it like on a breast.
Okay.
I think people are worried about if you did happen to have an hormone sensitive cancer.
Right.
We don't want to put a patch
hormones next
right
to
there.
it.
Yeah.
That makes sense.
Yeah. Well, then we can move on to the
Yeah.
injection, which I've never heard of before.
Really? You've
Yeah.
never heard of it? Have you ever
No.
heard of it as Depo or Depo-Provera?
I have.
Okay.
Okay, I have not.
Okay, so Depo gets a bad rap, and it's partially fair and partially not. I'm here to clear Depo's name. So Depo-Provera is just like quite a large dose of progestin, and we inject it either subcutaneously, so like in the fat that's between muscle and skin, or intramuscularly, and it works about the same in either place. And it works for a long time. So it's nice that you don't have to think about it. It's annoying that you have to like go somewhere for an injection. In some parts of the world, and even Canada, like if you work with your provider, you can set this up. Some people inject it themselves. And it works for 15 weeks. Not 15 weeks in one day, though. Really, ideally, we're doing it every 11 to 12 weeks. But if you come to me and you're like, it's been 14 weeks and 6 days, I'm like, oh, I'm not that worried. People who love it, love it. And it's also, after the Mirena IUD, it's probably our next most powerful way to suppress menstruation completely. So if people are like, I really don't want a period, my first choice for them is the Mirena IUD. But after that, if they're willing to try Depo, sure. Like, I think that's reasonable. The trouble with Depo is we're injecting it and then it's going to work for 15 weeks. But then the time to return of fertility or regular menstrual period can be even longer than that. So if somebody hates it, I can't get the medicine back out of them.
Right.
Like if somebody came into my clinic 2 weeks after an IUD insertion and said, let's turn this around, I don't want this at all, I can take it out. And within a cycle or two, they're back to their baseline. But with Depo, I can't. They just have to ride out those side effects for 15 weeks.
Okay.
So that's the downside of Depo. But The upside of Depo is we're pretty reliably suppressing ovulation. We're suppressing menstruation in a big way. And some people just feel so much better on it.
Oh, so it's a good option for some people.
Yeah, I say, like, don't knock it till you try it. It's not probably going to be the first thing that your provider suggests for you. I'll also say, so it's like, you know, can be a bit sad to think about, but for some people, consideration is they want to use birth control, but they can't tell the people in their life that they're using it because it's not safe to share. With Depo, there's truly no evidence that you have it, and it works pretty long term compared to something like the pill, where you have to hide the pill, you have to take it every day. What if you don't have access? And then also with Depo, like, we find that people who have precarious lives or a trauma history that would preclude them from getting an IUD, for example, or preclude them from taking a daily pill if that's just too difficult, Depo tends to be a good option for those populations. Okay. Something to think about.
Okay. No, that's good to know about.
Where do you go if, like, let's say our listeners, they're like, oh, I want this.
You can come to my clinic. So a lot of the community health centers, youth clinics have it on hand. You can, in theory, like, fill the prescription at any pharmacy. And then if one of the pharmacists at that pharmacy does injections, they can do it. If your provider is willing to train you to do your own injection, you can do it. Those are a little bit harder to arrange. I think the pharmacy injection fee is like $10 or something, but sometimes you have to pay for that. Anyway, a few options.
Okay. That's super interesting. I actually didn't know anything about the injection.
Yeah, me neither.
The other interesting thing about Depo is there are some forms of epilepsy that are triggered by the menstrual period, and we actually give people Depo, or this wouldn't be me in my practice, but a specialist would prescribe even higher doses than Depo to folks, and it can be an epilepsy treatment. Isn't that wild?
Yeah.
I've also had clients who have PMDD who cannot take estrogen for whatever medical reason, and we've tried Depo, and it's worked like a dream.
Great. It sounds like often not going to be a first line option, but like a great thing to have in the back pocket to try for people who need
We
it.
like to keep it as an option, preserve it as an option.
Beautiful.
Okay, so now we'll move on to the next class of contraceptive. So these ones are the most effective methods for preventing pregnancy. So they include the famous IUD that I feel that we have a lot of questions about this one. Then there's also the implant and sterilization, with fewer than 1 in 100 people using these methods getting pregnant every year. So very effective. So let's start with the IUD, so the intrauterine device. So first off, what is a IUD and how does it work in the body?
Okay, so it's a little T-shaped device. I cannot believe I didn't bring one. Anyway, you can Google it. I'm actually sure that most people know what an IUD looks like at this point, but it's a little T-shaped device, and it sits inside the uterus, and it prevents pregnancy in different ways based on if it's a copper or hormonal IUD. So the copper IUD, copper is a spermicide. It really just kills and confuses them, like they swim in circles. Yeah.
Not very smart.
Yeah, they're not. Their power is being in high numbers, not in being like smart individuals.
Right.
And then the hormonal IUD, it's thickening the cervical mucus and thinning the endometrial lining.
Okay.
Yeah.
And not suppressing ovulation.
Not reliably. It's still possible.
Okay.
But not in a way that we can attribute the effectiveness of the birth control to.
Okay, yeah, so that's
That makes
not how
sense.
you describe it as its function,
Yes.
but sometimes it will happen.
Yes, for sure.
Okay, good clarification. And what are the benefits of the copper versus the hormonal IUD?
So the main difference between the copper IUD and the hormonal IUD is the effect on your menstrual period. So the copper IUD is going to make periods heavier, and the hormonal IUD is going to make them lighter. The other nice thing about the copper IUD is, it's not all bad with the copper IUD. You're totally bypassing the possibility of hormonal side effects. So for some people, that's really important. And if somebody comes to me and they already have a light period, and they say, if this period gets 20 to 60% heavier, I can live with that. And some people, like, their period gets heavier or a little bit longer, and they barely notice. Great. I think that's a great outcome. But for some people, they come back to me and they're like, this is untenable. I can't do this. But yeah, copper IUD, great for a lot of folks. And then the hormonal IUD is truly, not only is it an incredibly effective form of birth control, it is such a powerful tool to suppress menstruation. So with the Mirena, we have a really good shot. It's really my best tool in my toolkit at giving you no period or very, very light period. The downside is you might have those hormonal side effects, and also the first 3 to 6 months you might have some unpredictable bleeding, I would say. So if you're somebody who like can't tolerate that, then maybe that's not what I'm going to suggest. The other downside to both IUDs, I will say, is the insertion process, which we can talk more about. I'd like to debunk some things and make people feel maybe, hopefully, more confident about it. But certainly there are lots of folks who will not consider an IUD because of what they have heard the IUD insertion process to be like, or their previous experiences of that.
Okay. Going back to what you said a little bit earlier, some people can fully suppress their period with the IUD. Is that in any way unhealthy?
No. So it's safe not to ovulate and not to have a period for long periods of time. If that's happening and we don't know why, I would want someone to have that investigated. But if we know that, like, if this is a known side effect of a form of birth control to stop having a period, that's fine. That's safe. So I know that there's a lot of fear mongering online about, well, what if you take the pill for 10 years and then you stop and you never get your period back? It's not that that's never happened. It's just that it's extremely rare, and then you do medical follow-up and you figure it out. It's not a common thing to worry about. On a population level, we don't see reduced fertility from long-term hormonal contraceptive use. What we do see is that aging reduces fertility. We haven't figured our way around that yet.
Right.
And there's a lot of people that are starting the IUD and they love it. They don't have their periods for like years. And then after like year 2 or year 3, they start having their periods again.
Yeah.
Is that normal, or like what could explain that?
Yeah. So the amount of hormone in the IUD that's being released is going to slowly dip over the however many years you have it. So with the Kyleena, we're talking about 3 to 5 years. So basically on the box it says 3 years, but we've studied it up to 5, and it's just as effective for birth control up to 5 years. But we do find that people between that 3 and 5 year time frame are going to get spotting. It's quite common. For the Mirena, you can use it for up to 8 years as really effective birth control. But again, the further you get into that 8 years, the more likely it is to have your period come back or have some spotting or have heavier bleeding. And so I do say to people, just because we know this works for contraception for 8 years, if you're unhappy with your bleeds at year 5, come back. Or even sooner. Like, we can even have a conversation about it. For people with really, really heavy periods, if we find that switching a Mirena out every 3 years for them is what works, great.
Okay.
You know, I'm fine with that.
And for someone that's not sure if they want to get pregnant, because I know we're at that age now, it's like in mid-20s, you're not sure if you want to have kids in the next 5 or 8 years, because it's like a big, like, long-term commitment to this IUD. So would you recommend it even if they're like, oh, I might have kids in 3 years or 2 years?
I'm fine with that.
Okay.
Truly. Like, you could make an argument like, oh, you know, the resources, if like it's a $400 IUD and you're only going to use it for a year, is that really worth it? I think that when a birth control works really well for somebody, the benefit is not quantifiable. So I'm fine with that.
Although they do have to consider that they have to come back in to get it out, whereas like another birth control, you could just stop. So I guess it just depends how soon.
Yes, for sure. Like, if you said to me, in 3 months, I'm going to try to conceive, I want an IUD today, I'd be like, okay, but you're going to have probably some unpredictable bleeding, and then you're going to come back, and then you probably need a couple cycles to track your ovulation. Like, are you sure that this is... I still wouldn't say no, probably, honestly, if people were really set on it. I want people to think of it as like a long-term potential benefit. Like, if you go through the IUD insertion process, you might get 8 glorious years of highly effective birth control and, you know, maybe even no period. But you're not locked in. It's not a mortgage. Like, you can, if you come to me at any point in the 8-year potential lifespan of the Mirena and you want it out, I will take it out. And I will say, I don't recommend this officially, but in the COVID, when people wanted their IUDs out, because they're like, I'm not doing anything, I might as well have a baby, and they wanted their IUDs out, and we weren't seeing people in person, there was, from one of the main sexual health organizations, a info sheet about how to take your own IUD out. If you're just using your own fingers, trying to feel the strings, grab the strings, and take it out, like, it's very, very difficult to hurt yourself. The main risk is that you don't get the whole IUD out and you don't realize that. And then you're like, why can't I get pregnant? Or, you know.
So we don't recommend it, but I guess it's
We don't recommend it.
possible.
But if part of why you're not considering an IUD is you're like, I will be stuck and I will be reliant on somebody else to take this out of my body, let me tell you, people accidentally take their IUDs out because they think that they forgot a tampon in there. And they like just pop it out on a glass of Chardonnay, like all the time. Like if you want to try to take it out yourself, and knowing that that's an option is psychologically soothing to you, have at her.
Okay.
If people accidentally do it, I'm like almost never worried. Ideally you keep it and you send a photo of it to your family doctor or your nurse practitioner and be like, is this the whole thing? Did I get the whole thing?
Okay, super interesting. Yeah. Okay, we have a couple of questions directly from our audience about IUDs. The first one is, why don't we provide more pain management for inserting IUDs?
I think that's the main barrier for a lot of people to get it.
Yeah, for sure. The answer to this could be a thesis. So, I mean, is it partially misogyny? Yes, for sure. Like, the healthcare system hasn't cared enough about folks with uteruses and their, like, comfort, health, et cetera, since time immemorial. And also, it's more complicated than that. So, like, we're not just being assholes. The system's not just being unfair. There's a few things going on. Part of it is some people aren't trained to do the pain management. We need to fix that. I was trained to do the pain management. And in my practice, if I was in a situation where I wasn't supported by the clinic with the right supplies, I just wouldn't regularly offer IUDs. Like for me, offering IUDs means I can offer various tiers of pain management. Part of it is red tape. So there's a new IUD pain management option called Penthrox, which is like a whistle and you inhale laughing gas, essentially. But it's very, very hard to do that in a healthcare context because there's a lot of regulation around what supports you need to manage an emergency in that case. So there's red tape, meaning we can't offer that in lots of outpatient settings.
Okay. Sorry. So you inhale laughing gas?
Yeah.
So you just laugh?
Well, we call it laughing gas. Have you ever seen someone like break their leg and the ambulance comes and they give them a little whistle? And they like inhale it.
I've also heard of people getting this with their IUD insertion recently.
Yeah.
Oh.
And in the moment, it's interesting. It's interesting when people use this because in the moment, like they are clearly still in pain, but they don't tend to remember. Like you don't register the memory of it.
Yeah. My friend who had this done said she felt like she knew there was pain, but it wasn't her pain.
Yeah.
Which is great.
Yeah. we give similar sedation for like when people break their leg and we're transporting them somewhere, or like even when they're getting their tonsils out. Like it just makes you not care. Yeah.
But that in outpatient clinics, it's harder to get.
Yeah. Most people are not set up to be able to do that according to the regulations.
Okay. Would you say it's getting better in general about how often it's being offered?
I like to think so. Yeah. But even if we can't do Penthrox, we can do a cervical block. I think everyone should be offering a cervical block. So let me break it down. Okay, the things that hurt with an IUD insertion. Putting the speculum in shouldn't hurt. If it's hurting, something needs to change in the practice. Now, some people absolutely have pelvic pain and all speculum insertions are going to hurt for them. I'm not talking about them. I'm talking about the average person who doesn't have a chronic pain condition affecting the vulva. So the speculum insertion, the practitioner should be really good at this and be able to place it without pain. We have to clean the surface of the cervix, and that's probably going to be about as painful as a pap smear. And it also has to do with like, you know, the rapport between the client and the practitioner and how good that practitioner is at doing this. The other thing that hurts is putting what's called a tenaculum on the cervix. So most uteruses are sort of flipped forward on top of the bladder, and then you have your cervix kind of here. And so we need to put a clamp on the cervix to kind of pull the uterus straight so that we can measure the length of the uterus and then insert it. The tenaculum is like a clamp that we have to put on the cervix. It hurts to put it on, for sure. That's what the cervical block is for. The cervical block is like getting lidocaine at the dentist. You're not frozen when you get the needle, so you feel the needle. So some people find the cervical block itself painful. So then what do we do about that? Well, we can put, like at the dentist, some topical lidocaine on the cervix to help with the pain of that. The evidence for that isn't great. When we study it, people don't find that it helps very much with the pain of the cervical block. But I don't know. Anecdotally, I find it's a good option. And some people really benefit from it. So these are sort of my layers of, we could do a topical, we could do a cervical block, and then that helps with the tenaculum pain. And it also tends to help a little bit with the pain of the insertion itself. But when we insert an IUD, the uterus needs to cramp. When we measure,
I remember for me when I got one was the measurement part.
Yes.
That hurt a lot.
So we're not doing this just for fun. Like, we need to measure the length of the uterus so that we put the IUD in far enough that it's effective. Because if it's not in far enough, it can reduce the effectiveness. And I wish we all had the same size uterus, but we do not. So we need to figure out how many centimeters are we talking about. And when we're measuring the uterus, we go right up to what's called the fundus, which is like the top of the uterus. And when we touch that part, it cramps. And it's supposed to. And we can't really fully get around that. Like, even if we could fully stop it from cramping, I don't know that we'd want to, because the cramping also prevents too much bleeding, right? Because we're disrupting the endometrial lining and we want it to stop bleeding, and compression of cramping helps with that. So should we be doing better with pain management with IUDs? Yes. Can we eliminate pain completely without completely like sedating you? No. But in my experience, when I set out the menu of options, and the one thing I forgot is Tylenol, ibuprofen. Ibuprofen is more important, but I say we're building a house of pain management. We're starting with the foundation. That foundation is Tylenol and ibuprofen. Then I set out a menu. I'm like, okay, what of these pain management options are we doing for you today? I think that the process of sitting with someone and they're acknowledging, I care about your pain, you get a choice in this, and you can stop or pause the procedure at any time, is in and of itself a pain management strategy.
I totally agree. I feel like if people go in blind and then they're just shocked by something that's happening that they haven't been explained at all, it's so much more painful and scary.
And then if they find out that there was other things we could have tried, like even if we build a great pain management house, we're doing ibuprofen, Tylenol, we're going to do the topical, we're going to do the cervical block, we're going to do, Penthrox, and then somebody has a terrible time with their IUD. In my experience, people are like, well, then that is what it is. That was what it was. We tried. You were on my team. We got through this together. Yes, it sucked, but I don't feel like I was abandoned or deceived, or that my experience of this didn't matter.
Yeah.
Anyway,
Wow.
I'll get off my soapbox now.
I liked how you explained the steps, because I think that's reassuring probably to a lot of people that don't know exactly what it is, what is going to happen, and they just get there and then they get contraction and it's hurting so much. So it's good to have
understanding what is going on, what this person is doing,
and the fact that
I think is really important.
Mm-hmm.
Do I have folks who like to just put their headphones on and like zone out and they're like, don't talk to me, just do it, let me know when it's done? Yes, and that is their right to do that. But the vast majority of people want to know what's going on and what they can expect to feel next, even if what they can expect to feel next is painful.
Yeah.
We call it verbal lidocaine sometimes, or verbal analgesia, of just the next thing you're going to feel is this, and big cramp coming.
Yeah.
And take a few deep breaths, and like it helps people get through, because it feels like, okay, we're a team, we're doing this together. The person getting the IUD has a much harder job, to be fair, but sometimes I think about it as I am the pilot of this medical encounter, but that person chartered the plane. And I will not fly it into a storm. I'm not going to do anything unsafe, even if you want me to. Like, I'll say no. But if they change their mind about what we're doing, where we're going, I will respond. They chartered that plane. I am their pilot.
That analogy.
Yeah.
That's great.
It's really good.
Okay, final question on IUDs from our audience was, are there any cons? They seem pretty great.
Well, I mean, TikTok would love to tell you about all the cons, right? Like about how it's so painful, and that they'll find there are risks with every medical procedure. Is it possible to perforate the uterine lining? Yes. Can we just talk about perforation for a minute? So most of the time when we're talking about uterine perforation, it means one of the arms of the IUD, because I'm a little IUD right now, pokes into the wall of the uterus, and it kind of gets stuck there. All we do is remove the IUD, and then we can wait 6 to 8 weeks, and then we can try again if you want another IUD. Now, is it possible to have a perforation where the IUD fully gets passed through the uterus and then floats around and we find like, are there case studies of us finding IUDs in various parts of people's body? Sure. Like, on a population level, with the millions of IUDs that have been done, all manner of awful things have happened. Sure. The risk is so incredibly low. And again, we're always comparing the risk of one thing to the risk of the alternative.
Yeah.
And the risk of the alternative is often getting pregnant. And not to put anyone off of pregnancy, but pregnancy is dangerous, is a much more dangerous thing for a body to go through than an IUD.
Okay.
Yeah. Okay, moving on
To
to the implant, which I feel like in Canada isn't the most popular, but I've heard in Europe is super popular.
Yeah. Well, Europe and the US had the implant way before we did.
Okay.
Health Canada really dragged its heels on approving it. It's the most effective form of birth control in Canada, more than a vasectomy, more than a tubal ligation, like sterilization.
Wow.
Isn't that wild? The body
Yeah.
finds a way. It's upsetting
Yeah.
that you can like go through an entire tubal ligation and still get pregnant.
Yeah.
But
Okay. And
happens.
then why do people don't have it? Like, what's the
people often don't know about it.
Okay.
And that's, I think, the main thing. So the implant it's about the size of a matchstick. It's made of a plastic that when we insert it under the skin of the arm, the body kind of leaches hormone out of it. And one of the reasons why it's so effective is you can't just lose it. Like, your uterus isn't going to expel it like it can with an IUD. Again, rare, but it happens. And you are always able to feel where it is. So you can always say, like, oh, it's not gone anywhere. It's never just going to pop out of your arm.
Can it move in your arm?
So it has ever happened that this complication has arisen. But mostly no. It just stays where we put it.
Okay.
So the body in its infinite wisdom, like, mostly a body is trying to get rid of a foreign object, right? But if it can't, like with the implant, it'll just put little bits of scar tissue to keep it in one place. So that's usually just stays where we put it. Once upon a time, I don't know that we've ever had this happen in Canada, but once upon a time, we would put the implant in a different part of the arm. So right now we put it kind of quite low, but we used to put it between the muscles of the arm here. And some people were not good at insertions. They would put it so deeply that it would go into a blood vessel, and there were a handful of cases where it migrated through the blood vessel, like into the heart or lung.
Yeah.
Very, very dangerous, very, very bad. Because that ever happened, we completely changed where we put the implant. So now we're putting it away from any major blood vessels, and we also changed how we trained people to do it. So we're putting it in very, very shallow. And we say, when you have an implant, you should always be able to feel it under the skin of your arm. If ever you can't, you go to the doctor or a nurse practitioner and you get scanning done to go find it. The other change that we made is we made the implant radio opaque. So it will show up bright white on all imaging. So it's really easy to find if it does migrate.
Yeah.
But again, super rare. Super, super rare.
Okay. And is this a progestin only?
Yes.
Okay.
Yes. So it's a really great option for people who just can't have the estrogen.
Right. And are there any significant negative side effects for some people?
Yes. So, unfortunately, this is true of all birth control, but for some people, they're going to have no period at all, and they're thrilled. For some people, they're going to have spotting for weeks and weeks or months. These are the folks who come back to me and they're like, I can't do this anymore. Take it out. And if they want it out, like, I take it out. It's absolutely their choice. But there's a couple things we can do to sort of salvage the implant. So we can try a month of a birth control pill to try to kick their body into like a rhythm of bleeding instead of just spotting. We can also try non-steroidal anti-inflammatory drugs. It's a long fancy name for, it's basically we do give them a higher than over-the-counter dose of Advil or naproxen for a short period of time to try to settle that bleeding down. So if people are willing to try that, to try to salvage the implant, great. But if they just want it out, that's fine as well. And then other people are going to have like regular bleeds. Like it's very hard to predict. But that tends to be the main reason that people get the implant out is that spotting.
And how long do you have it in?
So on the box it says 3 years. We know it works up to 5 for pregnancy protection when we like study populations who've had extended use, but it's like officially recommended for 3.
Okay.
And then the other thing I've noticed is like sometimes at 3 years people are getting their period back a little bit, or their bleeding is a bit more unpredictable and they want to swap it out, which is fine.
Okay. And is it like a surgery or how?
It's
invasive.
such a tiny little medical procedure. It's actually really fun to do. So it comes in, it's called an applicator. It's like this odd little device where we like slide it in under the skin and then we pull a lever back and then it like leaves the...
Kind of like a tampon inserter?
Like, yeah. Or sometimes I look at it and I'm like, this looks like a stapler. But it's not, we're not ka-chunk. It's like, shh.
Oh.
Yeah, it's really, the applicator makes it actually quite an easy procedure. The experience of getting it in is less pain than an IUD because I can numb the skin of the arm so effectively, right? Like, as we've talked about, I can't numb an entire uterus very well. I just can't. But I can numb the skin of your arm so that people don't even know that I've done the procedure. So you just feel pressure usually. Now, that said, there's pain with the numbing, like going to the dentist. You feel the prick of the skin breaking when I put the lidocaine in, but then you're good and numb.
Oh, great.
Perfect. Okay, well, let's move on to surgical sterilization.
So basically what they're doing is they are closing up the fallopian tubes, severing the fallopian tubes to prevent the egg from getting through to the uterus. It is a surgery, like a full surgery done under sedation. And so there are definitely going to be the risks of surgery with that. In the past, tubal ligation has been used for good and evil and also withheld for good and evil. So certainly there was what's called forced sterilization, particularly for Indigenous folks or folks with developmental disabilities in Canada, where they didn't want a tubal ligation or they maybe agreed to it under duress. And this was done for racist eugenicist purposes. There's also the issue of people who really want a tubal ligation who cannot access it because the surgeons say, well, you might change your mind, you don't know what you want, you don't have any kids, you're going to want them, or you're too young, or what have you. Now that we have the implant, I think the landscape has shifted a little bit. Like, I actually, when I look at the risk of a surgery, I think, man, if you haven't tried the implant and we have no good reason that you can't tolerate hormones, it is more effective slightly and way less risk than tubal ligation. Or like even try it while you're on the wait list for a tubal ligation, because then if you love it and it works really well, then we don't have to do a surgery. But again, I think anybody who wants a surgery and is able to consent to it should get it.
Can you talk about the risk of the surgery?
Yeah, so like anytime you're under general anesthesia, your anesthesiologist is responsible for keeping you alive because you're so sedated that you cannot keep yourself alive. So there's like always a risk. Now, anesthesiologists are very good at this, so I don't want people to be afraid of general sedation, but it is just at baseline a much higher risk than if you're in my office and I'm putting a dinky little lidocaine in your arm, for example.
Yeah.
And then also they have to do an incision through various layers of tissue to do the procedure. Often it's done laparoscopically now, so we're not like slicing open the whole abdomen, like it's not like a C-section. It can also be done at the time of a C-section if that's what somebody wants, but you need to plan ahead for that. But it is still surgery, right? Like it's still a lot more tissue damage than other forms of birth control that are, some of them are no tissue damage.
Okay, and so you can have your tubes tied.
Yeah.
There's also an option to just have your tubes removed.
Yes. Yeah. That's sort of beyond my purview. Like, talk to your surgeon about your options.
Okay.
Because we have so many great contraceptive options that are less risk than a tubal ligation, I find that if somebody's going to agree to an operation, we're often doing more things. Like, if somebody wants a full hysterectomy, I think it's an easier case to make, right? Because tubal ligation isn't going to fix fibroids. Or, like, if it's a gender-affirming hysterectomy, tubal ligation doesn't give us that. And so, yeah, I mean, it's really, you talk to your risk benefit about each procedure with your surgeon. They make a decision, you book OR time, and then you wait a while for it because it's technically an elective surgery. I will say Sex Sense keeps a list of surgeons who are willing to do tubal ligations as long as people do like an informed consent process, no matter what their age or how many kids they have. There are just some surgeons who will entertain the idea and others who won't. So if you're really dead set on a tubal ligation, call. Call to ask which doctor to get a referral to.
It might be a good option for someone that doesn't want to have kids.
Yeah, people who know, like, right away, I really don't want kids, and I don't want to have to deal with decades of birth control, and, like, I just want a permanent option.
Yeah.
And
there's no
I'm willing to
hormones.
wait for a surgical date and like, you know, do the recovery, and I'm tolerant of that risk. Sure. Great. Go for it. The other people who I see really benefit from tubal ligations are people who are really fertile and they like keep getting pregnant despite their best efforts. For some people, like if they've had multiple birth control failures and, you know, they know that they're done having kids, and sometimes we just get to that point where we're like, maybe this is our option.
Totally. Yeah. Okay. Final questions from our audience, which are kind of all about different types of birth control here. What is the best option of birth control if you want to avoid systemic hormones, which we'll have to talk about, and also avoid the pain of getting an IUD? I guess first question, what does it mean? What does systemic hormones really mean?
Yeah. So to me, systemic hormones means the hormones are getting into your bloodstream and having an effect through your whole system. So hormonal side effects could affect any like system in your body. So even though the IUD is working mostly locally, I would still argue that it has the potential for some systemic side effects. So I would say like all hormonal methods have the systemic side effects as a risk. I think I don't have enough information about this person's needs to recommend a specific method. Yeah. I think what I want to make sure of when I'm talking to somebody about non-hormonal methods, like avoiding hormonal side effects, is this like a real or hypothetical concern? Like, have we confirmed that they have side effects and that they can't tolerate these hormones? Or is it hypothetical, and is there misinformation there that we can debunk? But even if they've decided, like, I'm just not willing to take that risk, okay, then let's talk about our non-hormonal options in order of most effective to least effective, because we're assuming that this person wants really effective birth control. Okay, why are they afraid of an IUD insertion? Well, can we manage the pain? Are there options to make an IUD feasible for them? And then if they're saying, okay, no hormones, no IUD, then we are left with these less effective methods. And if somebody's okay with that level of risk, then I'm certainly okay with it too. The other thing is, I find it helpful to talk about, okay, what happens if you get pregnant? Like, is getting an abortion an option for you? Certainly in BC, it's legally an option. Financially, it's an option for people covered by MSP. Is it morally an option for them? That's an individual choice. Is it accessible to them? Like, is this somebody who works in rural areas for 6 months at a time and it would be very hard for them to access an abortion? Or do they like live in Vancouver? These are very different things. So I'm happy to make a contingency plan based on worst case scenario if this less effective method fails. I think it's worth talking about. And it also can be very comforting for people to know, like, a lot of people base their understanding of abortion access in Canada on US media, and it is just very different. So I like talking through like people's fears and worries.
Yeah. It's good to talk about it and to know that this can happen, and if it does, there's ways that you can take, and like you're not left alone with that.
I also fear that when they're choosing their contraceptive methods and thinking about effectiveness, they don't necessarily have that thought within them to be like, okay, if I was to get pregnant, how do I feel about that? You know, and that also is an important thought when you're deciding how effective you need your birth control to be.
Yeah, totally. And I say this all the time to my clients. I say, if you or someone you know gets pregnant and they want to know what their options are, just call Sex Sense. Or certainly come back to the clinic, talk to me. But it might happen to you, but it is likely to happen to somebody you know. And I really want most people to know and be able to communicate that abortion is one of the options when you're pregnant. Like in BC, it's covered, safe, routine procedure. Not without risk, but nothing is. And we don't have to live in fear of ever needing an abortion in BC, which is unfortunately not true about many places in the world.
Yeah. We have a few wrap-up questions for you. So the first one is, what advice would you give someone feeling overwhelmed? So today we talked about all of the contraceptive methods, and there's so many, and there's benefits to all of them, and then there's also risk. How would you tell someone like that's really overwhelmed? What would you say to them?
First of all, relatable. It's true that there's so many options, which is great. We love having options. But again, I think people feel so stressed about making an optimized decision about their health. They're like, I have to make the perfect decision, and if anything goes wrong, it's my own fault, and I should have made a better decision. And there's just a lot of pressure. So I would say, well, call Sex Sense, talk through your options. go visit your local sexual health nurse. We obviously want to talk about this and can never shut up about it. And also let yourself off the hook a little bit about this decision. Like, I don't need you to make a perfect choice. I need you to take the information that you have. I will give you more information. And then we together will make the best choice we can with the information that we have. Mm-hmm. And then again, we are still a team for whatever the consequences are.
Yeah.
So that's what I would say.
And you can change your mind and try another one if you want.
Yeah. And just know that the stories you see online are the anomalies, or they're going to be like the horror stories, or like, this is the best thing ever in the world. And you are statistically likely to fall somewhere in between. You're going to fall somewhere in between that spectrum of good and bad. And so don't let yourself be swayed by anecdotal evidence, but feel free to bring that anecdotal evidence to your healthcare provider so you can talk through it. Because I think that, like, it's silly to think that you're going to make a perfectly, like, rational, evidence-based decision. That's unrealistic. I actually want you to bring your worries to me so that we can talk through them.
Mm-hmm. Yeah, that's way better than just like sitting in silence and worrying about something.
And to be clear, if somebody came to me and they're like, I understand that it defies all logic and that there's no evidence for this, but the idea of having a device in my body, even if it's the most effective form of birth control available to me, is just icky and I can't handle it, that's a good enough reason for me to say, well, let's not do that.
Mm-hmm. Yeah.
There's no judgment there. I actually think that an embodied sense of comfort, or at least like neutrality about a birth control method, is something that we need to strive for. I'm not going to start you on a birth control that horrifies you. Mm-hmm. That's nobody wins. Like, I'm not doing that.
Yeah. Okay. Another big question is, what is one thing you wish more people knew about contraception?
Man, there's so many things. I think the main one is that, like, contraception is statistically safer than pregnancy. Again, pregnancy can be very worth it, right? High risk, high reward. But contraception, I actually find the risk reward ratio pretty good too. Like, lower risk and pretty good reward.
Yeah. Mm-hmm.
And also that this isn't a static thing. Like, you're allowed to change your mind about things. You're allowed to try different methods. I have people who come to me and they're like, I was on the pill when I was 14 and then I did an IUD and then I went on the pill again. And now, you know, I hated IUDs at the time and I said I'd never do another one, but I'm actually kind of considering it. And sure, great. You're allowed to change your mind. And also your medical picture and your medical needs will change over time. And so, like, do another consultation with your healthcare provider. Mm-hmm. That's totally reasonable.
Yeah. And I find it interesting that you're comparing birth control and all of their like effects and risks that they have, and we're just talking about all of the risk online, and it's just like overwhelming, and there's so many risks. But it's true that there's risk associated with other things like pregnancy, and we
not being on birth control has a risk.
Yeah, exactly. Right? But we don't talk about it that much.
Yeah, because you can't sue someone for not putting you on birth control when you never went to their clinic. Do you know what I mean?
Like, it's easy to put the fault on a medicine or something. Yeah.
But then people who don't go on birth control and get pregnant when they don't want to be, they get blamed by society, right? So it's just like, I think we all just need to be on a team where we try to get good outcomes, and if it doesn't work out, we walk alongside each other to figure it out.
Mm-hmm. Absolutely. Yeah. Okay, and last, before our really final questions we ask all of our guests, are there any resources that you'd like to recommend to people who might be listening and have some more questions?
I mean, obviously, Sex Sense. Mm-hmm. To be clear, what I love about Sex Sense is they have time for you in a way that, as a clinician, I don't, like, I really do try to have these conversations with my clients, but sometimes you need repetition, sometimes you need, like, a bit more in-depth, and sometimes you're asking things that are non-medical that I can't really get into. Sex Sense has time for you. Sex Sense is Options for Sexual Health's information and referral line. They're open Monday to Friday, 9 a.m. to 9 p.m. Someone please put the phone number in here. I don't have it memorized.
We can put it in the show links.
Okay, great. It's staffed by registered nurses, sexual health educators, like an incredible team, and they will talk to you about your thoughts and feelings about birth control. And then they'll also, like, provide you good evidence-based information, and I do just highly recommend them. Yeah, I recommend your local sexual health clinic. I recommend youth clinics, especially the ones run by, like, health authorities. I like scarletine.com. That's one of my favorites. I like the Planned Parenthood website. Yeah, I mean, there's a bunch.
Okay,
Yeah,
well,
that's a good
we'll
answer.
put them in the bio for sure. Okay, now our final question that we ask all of our interviewees. So the first final question is, if you could bust one myth about women's health forever, what would it be? I know it's a really big question.
I think it's that there's a snake oil on the internet. And by snake oil, I mean like an unproven supplement or device or something someone is trying to sell you on the internet that will solve whatever is going on with your body. And that if you just scroll far enough, you will find it. And if you spend enough money on it, it will work. Unfortunately, understand more and more as I train to become a nurse practitioner that bodies will sometimes fail. They are sometimes difficult or painful to be in. And there are medical conditions that can be treated, but sometimes bodies are just uncomfortable or painful. And we have symptoms. We can't solve every single thing. And that is a very vulnerable, difficult place to be in. And unfortunately, people will try to capitalize on that vulnerability and sell you something about it.
Because it works, unfortunately.
Yeah.
It works for them, not for the client itself.
Yes.
Yeah.
Yeah. And they make a ton of money on, an unregulated supplement. The other piece here is that people have started to equate natural with healthy. And I just want to say, like, without any medical intervention at all, even if we were eating perfectly organic, living whatever natural utopia people are talking about, people would still have PCOS. People would still have endometriosis.
Yeah.
People would still have hormonal symptoms that cannot maybe be answered by Western medicine, but they also can't be answered by these natural remedies, unfortunately. I can't speak to like anyone's specific case. Maybe they are going to find solutions in natural remedies. Maybe they are going to find solutions in Western medicine. But like, it is a fallacy that human bodies can all be made to be without symptoms with like natural.
Yeah, you can't buy something that's going to cure all of your problems.
No. And that actually, when we do medical interventions that are unnatural, we're preventing human suffering. And that's important too.
Yeah.
That's true. Yeah.
Okay. Very last question. What's one change you hope to see in women's health in the next 10 years?
I'm so tempted to do like a peace on earth, or you know what I mean? Like a very sort of pie in the sky answer. And it's true. Like, I do wish for reproductive justice and that for that to mean all sorts of things, for that to mean that people can access abortion safely and easily, but also for that to mean that people don't have to worry about raising their children in poverty. That said, the answer in my heart is a bit more of a self-serving one. So right now in BC, only medical doctors do first trimester aspiration abortions. Nurse practitioners don't do them. In other parts of the world, that is the case, that NPs and other professionals like midwives and physician's assistants do first trimester aspiration abortions. And we've seen that it's actually quite safe for that to be the case. My personal dream, and also my dream for the abortion landscape in BC, is for nurse practitioners to be doing first trimester aspiration abortions, because I think it would expand access enormously. And I think that nurse practitioners, when adequately trained, like, we are more than capable of doing that for our clients.
And it would make abortion more accessible.
Oh, for sure. For sure.
That's a really good answer.
Yeah. Well,
Thanks
thank you
asking.
for joining the Volvolution
Thank you
today.
for your great podcast. This is so fun.
I know that people are going to absolutely love this episode.
Oh,
we
I
answered
hope
so
so.
many of my personal
Oh my god, me
questions.
too. Yeah.
Yeah.
I learned so much.
Fantastic.
Yeah.
So thank you.
Yay,
Thank you.
Thank you.